center, where clinicians are basically treating patients and are in need of new technologies. So I'll highlight a few application areas that we've been screening. And also there I will focus on one specific application area where we try to translate basically towards commercialization and clinical translation. So first of all, the group. This is a group picture from last year. So our group size is about 20-ish, consisting of PhDs, postdocs, students, and so on. I think pretty comparable to your kind of groups. And this is a group picture along our river, the River Waal. We're proud of the river, of course. All the city in the Netherlands, etc., etc. So, but this is a typical picture of our group. So what do we do? I won't go into detail into all of these research lines, but just to give you a brief overview. Traditionally, we have been working on implantology, 2D implants, modifications. I did my PhD on this topic. We're moving a bit away from that topic because hard tissue regeneration in implants is quite well solved. So as of recently, we focus on soft tissue integration. But that's a line coordinated by my colleague Fang Yang. Then we have a line on bone cancer and ex vivo models. That's something I do together with my colleague Jeroen van der Beuken. He's a biologist. And we try to come up with alternatives for in vivo testing. And then that holds also true for the other two lines, tooth-on-chip models and bone-on-chip models. I guess you are very familiar with organ-on-chip technology. We try to innovate here by designing tooth-on-chip models, which are hardly there. But I think there's room for applications also there. And that's coordinated by Frank Walbomers. And then Mani Diba is a talented staff member that recently joined to set up bone-on-chip models. I will focus on the line that I initiated and coordinate myself still, besides my other tasks, basically. That's the design and preclinical evaluation of colloidal biomaterials for treatment of bone diseases. So why should we treat bone diseases? I think each of you knows that bone regeneration is a big field. And bone can be degenerated by many causes, such as trauma, for example, aging, but also due to many types of diseases. And many of those diseases, like cancer or infection, are degenerative. So they basically counteract any regenerative attempt you try to implement. So some of you might have already an oral implant. I received one last year. I see one in the audience that might face the same challenge, but it's not really a pleasure. So, and you really are confronted with bone loss. That's very hard to avoid. So how do surgeons treat these patients nowadays? This is the only bloody picture here. It's still manageable, I think. We're before lunch, so that should be fine. But this is the procedure that's performed on routine basis in our hospital. So basically, bone is transplanted from the site of harvest, the iliac crest in this case, towards the site of application, which is the jaw area in this case. I don't know if you have ever seen surgical procedures like this, or you all work on biomedical applications, I guess. But who visited the operation theater, actually, regarding the topic of your research? It's just an open question. And Keita, yeah? Not much. So I recommend really to do so. It's take-home message number one. Really try to somehow, and here maybe it's a bit more difficult, but I can help maybe if it's in orthopedics, for example. But please try to at least witness once in your PhD or project a surgical intervention, because it's pretty impressive and it changes your perspective on things and on life in general. And for me, for example, when I saw this procedure, it's really invasive, it's really bloody, it's really a massive wound. There are several assistants that need to open up the wound, and it's noisy, so yeah, it's not so sophisticated as you would expect. Although it's very high tech in the end also. So for me, this was a motivation to contribute to the field of bone regeneration, which is in quest of finding alternative solutions for this. Patient's own bone, basically. This is called autografting. That's still the gold standard, but it's still challenging. So like, why not develop artificial bone? That's of course not a new question, so owing and thanks to several of our predecessors from the 70s and 80s and until the 90s, lots of research has been performed in the biomaterials field on the development of these kind of granules and scaffolds and so on. They perform very well because they are based off calcium phosphates, so basically bioceramics. Why would these materials perform very well in bone? Do you have any idea? So what's the reason why calcium phosphate ceramics are the most popular type of bioceramic? Silent faces, sorry? Similar composition to bone, basically, yeah. So the mineral phase in bone is a bioceramic. And that's why these materials perform very well. So, but we're still dealing with quite some disadvantages, which include the clinical handling. The materials are very brittle, which complicates their handling. The degradability is very poor. Hydroxyapatite hardly degrades, and the biological activity is very limited. It's not bone itself, it's just a material. So these are our challenges, basically. So I would like to have an interactive lecture. So I put these question marks in between. So do you have any questions on this field so far? Everything clear? Understandable? Yeah? So please interrupt me when you think you would like to ask something. So what we try to do is we try to learn from bone, basically, in our design of biomaterials. And we do so by taking inspiration from bone, and bone is a nanocomposite. It's built of nanoparticles. The hydroxyapatite is a nanoparticle. The collagen fibrils that we have in bone are nanoparticles, basically fibrillar building blocks. And that's a different approach in biomaterials design. So we use building blocks that are nanoscale. So that's a new challenge in basically in our group. Then secondly, we should realize that the building blocks are not just organic or not just inorganic. So we believe really that we should adopt a composite approach. So really combine these particles from different sources. And something that's often neglected, I don't know if you are working on bone-like materials, just from my understanding, who's working on bone? 1, 2, 3, quite a lot actually. So many things that I tell right now are familiar, but I think it's important to stress indeed that bone, from an engineering point of view, is a nanocomposite. So it's not just like, as I sometimes jokingly indicate, like a kitchen machine approach where you just combine some components. But these components are intricately linked together. So the interaction between these building blocks is very important. So this is basically how we try to come up with new materials that are able then to overcome the disadvantages that I just highlighted. So that's quite a challenge. I focus first on the use of nano-sized building blocks, which by that time, about 10 years ago, was quite a new approach in our group. So just a theoretical intermezzo, like the field of so-called colloidal materials was already established for quite a long time. Materials like shampoos and many cosmetics are basically colloidal materials. And what does that mean? It means that you have developed, composed a material fully of nanoparticles. So not nanoparticles as a component that you can add in, but that you build by self-assembly materials fully made of nanoparticles. So when you combine nanoparticles that repel each other, that have a similar charge, that won't go. That's the upper picture that you see, like a repulsion of the particles, which ends up in a liquid-like behavior. And that's not very reliable if you inject something in a body cavity. But if you combine particles that are, for example, oppositely charged, or by other means interact with each other, so that you have attractive interactions, it is theoretically possible to make these shape-stable, three-dimensional networks that are shown here on the bottom picture, this one. And I have the chance to use these old-fashioned but very triggering devices. So this is the type of networks that we try to achieve. And that was known from colloidal materials for a long while, and I was interested and intrigued if you could do so also in biomaterials, because nanoparticles are, of course, very interesting materials. So our quest started about 10 years ago. This was the first approach, where we started with a fully organic approach based on gelatin particles. And why gelatin? Any idea? Why would we use gelatin as a starting material? I think some of you use gelatin as well, so they should have some sort of clue. Any idea? What's the attractive component or the feature of gelatin? Yeah, go ahead. It's collagen derived, yeah. So you could call it a bio-inspired approach or biomimetic approach, and because it's derived from collagen, it contains many adhesive sites, it's biodegradable, you can tune the degradability. A very pragmatic benefit for this approach particularly was also the fact that we could buy different types of gelatins, first from Sigma, later on from a real gelatin producer, because we want to go to applications at different charges. So there's cationic gelatin, there's anionic gelatin. And we like to keep things simple. We are not polymer chemists, so when we can just buy it, it works out fine. So we did so. We bought positively charged gelatin, negatively charged gelatin, combined these particles, and then observed indeed this interesting network formation, which then gave rise to extrudable pastes, basically. So that was a very nice outcome, a first attempt to make extrudable materials, overcoming one of those disadvantages of bioceramics by themselves. These are brittle, they're very clumsy to apply in a defect, so this would be more advanced. So that worked very well, but by that time we were more experienced in working with microparticles. So we were not really into nanotechnology by that time. And so we still compared the performance, the functional performance of materials made basically from microparticles or nanoparticles. So microstructured gels or nanoparticle gels, hoping that we could still use the more simple microspheres that we were used to work with. But it became very clear very soon after working with these materials that that was not the case. Here you see, for example, clinical handling tested by injection of these gels, these nanoparticulate gels or microparticulate gels, into warm PBS. And then you could see that we observed a phenomenon called filter pressing. Are you familiar with filter pressing? Not really, it's more from ceramics, but it means that if you have a ceramic suspension and you extrude it, the water flows out first and the material is left behind, and that's exactly not what you want, basically. And there's always a challenge for suspensions. So you could see there on the left pic that the gelatin was left inside and the liquid was flowing out. If we compare then the performance of nanostructured gels on the right, the gel extrusion was much more homogeneous, and also the cohesiveness in this warm PBS was much better. So there was one added value, and this also was reflected in the extrusion force measurements that we performed. We want to have like extrusion that's humanly possible, and orthopedics always indicate that they are 10 times stronger than an average surgeon, but still it should be something that you can extrude by yourself. And then if you take this one, the red one, so these are made of microsphere particles, we could see that the injection force rose too dramatically. This is going up to forces that are not desired, and that's caused by this filter pressing. Whereas the nanostructured gel had a very smooth extrusion profile until the piston hit the end of the syringe, and then you have this rapid increase. So that's a very practical advantage. And then another advantage that triggered my enthusiasm even more was the fact that these materials were very self-healing. And by that time, self-healing was more a fancy term that was observed in many gels, and everyone liked to work on self-healing materials, including me. But what is shown here, basically, I will explain the concept, is that if we have materials of initial similar storage modulus, are you familiar with rheology, storage, viscoelastic properties? Yeah. So on the y-axis, you see the viscoelastic parameters, and our materials were initially similarly stiff, let's call it that way, solid-like, so 10 kilopascal. But the materials composed of microparticles did not recover their stiffness after this destructive shearing. So here the material was basically destroyed by a very severe 1000% strain. And then afterwards the nanostructured materials in red recovered up to 90% of their initial stiffness. So it was a very interesting phenomenon. I was not really sure like how to interpret this and how to use it, but I was then involved in a program called Self-Healing Materials Program, IOP funded, which by then was mainly focused on civil engineering. And I don't know if you have followed the news, but there is now self-healing asphalt. There is self-healing concrete, thanks to bacteria filling up cracks in this concrete. And it works, unless you're not afraid of the bacteria inside there, but it's safe. So it's quite an inspiring field, and I set myself as a goal to show that also self-healing biomaterials can have an added value. So here it's just like an intermezzo showing the advantage of potential self-healing. Of course, mechanically speaking, like if your material is self-healing and if your material is supposed to function for a long time in the human body, then it's an advantageous feature if your material survives multiple shearing, multiple destruction, such as shown here by the Langer group and many other groups. So that's obvious, but less obvious, I think, is something that we recently tried to propose, that self-healing injectable materials in this review are a specific class of materials that enable new technological advancements. Because basically for some applications, self-healing is an absolute requirement. It's not just a fancy add-on. It's a true requirement for full functioning. Because if you work with small needles, with minimally invasive delivery, for example, into a body defect, or with printing at high resolution, you are dealing with extrusion printing, basically, with very small needles giving rise to high shear forces, which may destroy your material, such as shown in this phase 2. And that's basically corresponding to this phase 2 of the rheology graph that I showed. So the network is destroyed. So only when your material is self-healing, you can retain the original stiffness, the original solid-like behavior. And that's for many applications like the ones shown here, an absolute requirement. So I think for many materials you need self-healing to be fully functional. And then the third one, that's a potential biological benefit. It's a bit more speculative, and not many groups are active in this field. But it's mainly based on some observations that we did about 10 years ago, when we compared materials that were self-healing on the right versus non-self-healing, owing to different bonds between the components. But the composition of these materials, which was injected in this defect in the knee, this is a condylar defect in the knee, injected with a gel composed of hyaluronic acid with calcium phosphate, so more or less bone-like composition. But the left one was covalently cross-linked and the right one was non-covalently cross-linked. That was the only difference, but the composition was exactly similar. And I don't know if it's clear, but you could see that bone infiltration for the self-healing material was more homogeneous, more rapid also, which is interesting because it could be related to the fact that these non-covalent bonds allow for more permissive cell behavior. So cells could grow into the material, stem cells, more easily. Perhaps, this is a speculation. We didn't have time and funding to go deeper here, but I still believe that the fact that self-healing is often related to reversible bonds rather than irreversible bonds allows for a different biological behavior. So far my defense for self-healing biomaterials, because not many groups work on this topic. But we tried to make them ourselves and then switched gears around 2015 by focusing on composite materials. I explained previously bone is not just organic, it's not just ceramic, it's a composite, so why not try to advance the field by developing novel composite materials. So that meant that we chose organic and inorganic nanoparticles. So we added basically inorganic nanoparticles to the system. We tried to tune the interaction between these two types of particles, not just mix and wait for the magic, like really try to tune it. So this PhD student by that time, Mani Diba, he came to our lab and he had experience previously obtained from his stay in Erlangen, where he worked with bioglass nanoparticles. So he proposed to work with silica-based nanoparticles because they're highly tunable, they're spherical, and we thought that would match best with spherical gelatin particles. And he was also interested in being able to tune the interaction between these particles. So we mixed those particles, negatively charged silica and also negatively charged gelatin at high pH, so pH of about 10. Then you have this liquid-like behavior because you have repulsion, they're all negatively charged. But when we then add an acidifier, reducing the pH gradually, like we were hoping to introduce these attractive interactions that are required to induce self-assembly and to get this solid-like behavior. And that worked out well. Schematically, of course, that's most easy to draw a nice picture, but we also observed in confocal microscopy that by mixing green and red silica and gelatin particles, we could observe the overlap, stressing the network formation in yellow, basically. So there was a first experimental proof that we were actually building these materials, and that was shown also in this nice video. On the left bottom, the left top picture, you see green silica and red gelatin particles moving together in a liquid-like manner. And then the pH is gradually reduced, so you can see that at a certain point the network is arrested, and the color becomes yellowish, so there's overlap. And that's really very strong proof that we were able to form these networks as we were hoping for. And that reflected in reduced particle mobility on the top right, and then also higher G prime, higher storage modulus than loss modulus, so reflecting gelation. So there was the basic research giving rise to this line of research on colloidal composite biomaterials made of silica, made of bioglass, later on also hydroxyapatite. And by tuning the solid content and the ratio, and so what engineers like to do, we could end up with extrudable materials, very elastic moldable materials, or even these nanostructured ping pong balls. So it's just funny that it's just a collection of nanoparticles bouncing there. We are located at the Faculty of Dentistry, so I proposed to work on cartilage, but the dentists were not very enthusiastically responding to any cartilage. There's not much cartilage except for some small spots in your jaw. But I know now groups in China, for example, are trying to use these kinds of materials for cartilage. All right, so that's more or less a summary of the benefits, potential benefits, based on the material science. This is the end of my material science part, where I think that these colloidal biomaterials here shown in a schematic manner offer the opportunity to have advanced extrusion and printing behavior due to their self-healing capacity, which is very evident, especially for the composites actually, because there's even better interactions. These materials are intrinsically porous, so you don't need to add any porogen, because due to the self-assembly there are particle-rich areas and particle-pore areas, so basically formation of pores by themselves. And since these interactions between the particles are non-covalent, so basically reversible, we also observe that the materials behave in a more dynamic, adaptive manner, and that opens new opportunities to show if you have enhanced cell or tissue ingrowth. Personally, I think the main benefit of these kind of materials are basically the fact that they are made of nanoparticles, nothing else. So you can use nanoparticles for nanomedicine approaches within regenerative medicine. I think that's quite a new approach, because you can, for example, deliver, such as is shown here, nanoparticles which are released from these materials to a small extent, but it's shown, both experimentally and in models, that these materials release nanoparticles. And then you can, for example, deliver drugs inside cells, like is shown here, for certain therapeutic properties. That's basically impossible for traditional bulk biomaterials. There you have to wait for weeks to months to years maybe before the size of the component is small enough to allow for intracellular delivery. So here we have another question mark. So there's more information that has been shared with you. Any questions? Yeah, Lorenzo.
Did you suppose size of the nanoparticle? Because in our more drug delivery field, 100 or 200 nanometers is a huge difference. Does it matter here?
Yeah, it matters for the viscoelastic properties, of course, and we can vary to a certain extent, but I have to admit that you are somewhat stuck for each category. Like silica particles, for example, you can make from extremely small, like tens of nanometers to hundreds of nanometers very easily. For example, for hydroxyapatite, I come to that later, that's way more complicated because it crystallizes, it adopts different shapes and so on. But we tested, well, for example, the size matters a lot for these kinds of materials. This is like a schematic impression, but it's corresponding to the sizes that we used in our materials. And there we observed that the fact that the silica, the greenish particles, were way smaller than the gelatin ones was actually beneficial, because it could fill up the interstitial spaces between the gelatin particles, and that gave rise to this super high elastic behavior that was not possible if the particles were similarly charged. But it's a very intriguing field, because you can basically mix everything and take every nanoparticle that you like, but that also creates the complexity, because the complexity is virtually endless. But yeah, now for sure it has a big effect. Yeah, any other questions? Yeah, go ahead.
First thing, gelatin tends to melt almost immediately at 37. So when it's in the particle shape like this, is it similar, like it melts almost
No. That's it.
When
I forgot to mention, but these particles are cross-linked. So with initially glutarialdehyde, later on more body-friendly, cytocompatible cross-linkers. you have to stabilize them indeed, otherwise it becomes a liquid pretty soon. Yeah, yeah.
It can still be degraded by the cells then?
Yeah.
I know from
Yeah.
gelatin and most of the crushing curves that cells can't really degrade it anymore.
Oh yeah, but it can be degraded. There's proteases present, like for collagen, so the degradation. Actually, it's a challenge to reduce the degradation. So now it's in a couple of weeks, few weeks to 1 or 2 months, then it's degraded. As a composite material, that process is reduced. So that's a tool to reduce degradation speed. Yeah. So far, so good. So that was the material science. Now let's move to applications that I promised at the beginning. So this is more or less a historic overview. We started with, let's call it healthy bone. That's a bit of a tricky term because you never know if you're healthy yourself, but at least there was no underlying disease known in the models that we used. So this was the first attempt, so just to start checking how these materials performed. And there we focused on growth factors. So in general, our applications are all based on the fact that we use the nanoparticles to deliver drugs, anti-cancer drugs, antibacterial drugs, or anti-resorptive drugs for our second case, osteoporosis. And in time, we have zoomed in more and more on conditions, diseases where you can really benefit from the nanoparticles, because we started with growth factors, and there the benefit was that the nanoparticles have a high specific surface area, so that the control over delivery could become better, and that was dearly needed by that time, because we were, by that time, I don't know if you still remember, but the Infuse scandal, does it ring a bell for some of you? Infuse was a growth factor releasing product, the main growth factor releasing product launched by Medtronic, early 2000s. It worked out well, very well actually. It was a blockbuster product for Medtronic until people found out in orthopedics that there were major side effects associated with overloading. So there were super high amounts of growth factors applied to a collagen sponge. Control over delivery was very poor, and that resulted into ectopic bone formation and quite a long list of undesired side effects. So, of course, we could do better, but we found out in time that it was not really the best market to assume that you could bring a growth factor delivery product in the market around 2012-13, when this became known in the public. But still, yeah, we could observe that if you have a 3D printed segmental defect, such as shown here, in collaboration with Erasmus MC, and when we loaded a gel, which was then loaded with growth factors, we could achieve these unions that in orthopedics are needed. So you want to have bone ingrowth from both sides so that your segmental defect is effectively repaired. So that worked pretty well. But for more non-scientific reasons, we abandoned the field, and also because we thought like the material is too complex with nanoparticles and upscaling and so on. Like you should really have a much more better performance than conventional sponges, and we thought that would not be the case. So we moved into a more challenging conditions, osteoporosis. This is another approach where we functionalized our gelatin particles with bisphosphonates. Is that type of drug known? Bisphosphonates or alendronate or these kinds of drugs, yeah? These are the #1 drugs used for treatment of osteoporosis because they kill osteoclasts, the cells that degrade bone. So if you kill those cells, then bone density increases. But bisphosphonates also bind extremely strongly to the mineral phase of bone. I've worked quite a while in this field, and I don't know of anything else that binds as strongly to bone as bisphosphonates. So then we thought to hit 2 flies in one hit, as we say in the Netherlands. So to use the bisphosphonate as a drug to modulate cells, but also to act as a link between the gelatin particles, the organic component, and then the inorganic component, which in this case was bioglass, but we also worked with silica. So it's basically glue. So we first tested the adhesion between those bioglass particles, which we glued to a cantilever for AFM. And then we measured adhesion to gelatin, a monolayer of gelatin functionalized with bisphosphonates. And then in the gray bars over there, you can clearly see that those functionalized particles indeed gave rise to more adhesion. And that boiled down also to improved mechanical performance of these gels. So especially at lower volume fractions, there was a clear added value of using these links, these glues basically between the particles. We had a better integrity of the material. And when we injected these materials in a similar defect, also in vivo, so in a rat, we make a hole in the femoral condyle and we injected the material, then we observed that overall the bone response was quite good for all of the materials, but the ones in gray that were highest were the ones functionalized with this bisphosphonate drug. So upon degradation, the bisphosphonate was locally released, thereby killing locally the osteoclast and giving rise to more bone formation, which was exciting, but then slowly also realized this is an osteoporotic model, by the way, so it's a diseased rat. But we realized that we can never cure this disease, because osteoporosis is a systemic disease, so maybe you can give bone formation a temporary boost, and the nice aspect here is you don't need to apply drugs systemically at very high doses for long times, but still it's a transient effect, so we cannot really cure osteoporosis in this manner. So we were looking for other applications by that time that would really benefit from a more boosted temporary effect, and found that application area in bone infection. Bone cancer is another interesting field, but in view of time I won't focus on that topic here. But I would like to focus on bone infection because that's what we basically selected as our field of application. Well, bone infection is a huge problem. Lorenzo just left the room. I understood he has bone infection going on right now, so you see how urgent this is. But it may happen in orthopedics around implants, starting from a biofilm. It may happen spontaneously due to diseases like osteomyelitis, so bone infection within the bone itself. And it's detrimental because it's degenerative, so you end up with major bone loss. And since bone is your load-bearing tissue, that's basically a huge problem. So currently, we interact now also with many orthopedic surgeons. We are located at dentistry, but at orthopedics, they are particularly concerned about bone infection because it's deep down in your body. So if you have an infected hip implant, basically the patients are then bombarded. This is the association that I have with this kind of treatment. Now it's 3 months. Until a couple of years ago, it was 6 months of heavy antibiotic treatment, systemic. Also locally, I've seen people applying really like antibiotics in huge amounts locally just to do something, because basically if you interact with these surgeons, and last week we had a surgeon in our group giving a seminar, and he told the impact that it has on patients because it's basically comparable to chemotherapy. Such a long administration of antibiotics is really highly detrimental, but also for the surgeons themselves. And that's not something I thought of before, but he told me if we are facing too many hip infections per year, it's really draining the energy of orthopedic research, of orthopedic clinics group, because it's very hard to treat, it's frustrating, there's nothing available basically except of cleaning and overloading with systemic antibiotic treatment. So they are really needing something to be more sophisticated. There are some products available on the market that promise local delivery of antibiotics, but to be honest, this is not really a viable alternative because there are cements available releasing antibiotics, but in practice they don't release, so only 1% is often released because the cement is hydrophobic and the drug hydrophilic. There are these sulfate cements or calcium phosphate cements that supposedly release antibiotics, but the release is often too fast, so within a couple of days everything is gone. So it's not possible to sustain the release, and that's, I think, where we could benefit from our colloidal materials. And thereby overcoming these problems that I mentioned here. So the failure rates are extremely high after recurrent infection. And that's all caused by the fact that the control of the delivery is very poor. So that results in these two major challenges, clinical challenges. Antibiotic resistance, I don't need to explain anyone here in the audience. I think this is going to be one of the major healthcare challenges worldwide. And if you bombard your patients with antibiotics, it's not going to improve. And something that's often forgotten, but which we believe very strongly on after interacting with microbiologists, people don't realize often that bacteria are not only residing extracellularly in the matrix, but also inside cells, and sometimes for very long times in a very passive state. So bacteria can be internalized by cells like macrophages that are supposed to clean them, basically, but they can reside in those cells, and that's a big problem. And there's no solution for that because most of the antibiotics used for treatment of bone infection are not able to penetrate the lipid membrane because they're so hydrophilic. So you can bombard whatever you want, but if they don't enter the cell and also kill cells intracellularly, that's a problem. So this was our dream a couple of years ago, and we got some funding to investigate this topic further. This is a happy cell growing over a colloidal biomaterial that's infected with this purple bacteria, internalizing the particles, which then are loaded with antibacterial agents, and then kill also those nasty bastards inside the cell. That was our dream, and then the cell would live happily ever after and enter the porosity of the material. Okay, so this is, of course, this takes a while to make a video like this, but it doesn't match necessarily with reality. But I think we have some interesting scientific evidence right now, meanwhile, that this dream may become true. So first of all, a student that worked here, Jiankang Song, he, after our PhD in Nijmegen, he moved to this building, actually. He showed for the first time that the organic nanoparticles that we used could be used for intracellular delivery of an antibiotic called vancomycin. And vancomycin is the gold standard, so that's the #1 type of antibiotic used for bone infection. The problem is that this antibiotic does not enter cells. And that is something we observed also in these transgenic zebrafish. These are zebrafish models that we worked on together with Bassat in Amsterdam, UMC. And the macrophages are stained red, basically, so that allows for visualization of particle uptake. So the macrophages internalized our nanoparticles, but the interesting part was that they also internalized the green-colored vancomycin inside the cell. And in many controls we showed in cell culture, but also in the zebrafish, that the vancomycin by itself is not able to do so. It cannot enter the cell. And that's a problem. So we pursued further. We used these poor infected zebrafish. So we offered them first S. aureus, a very aggressive pathogen, and checked that these bacteria end up in the macrophages, these transgenically red-colored macrophages, confirming that we have intracellular infection. And then we subjected them to different types of treatment, including let's check the blue line here. That's the gold standard, basically, systemic delivery of vancomycin. And then the y-axis means survival. So basically, after a few days, all of the zebrafish were dying, which is a sad story, of course. But with the nanomedicine-based approach, the VGN, vancomycin gelatin nanospheres, the survival was substantially improved, actually. In the end, they still died, of course. That's hard to avoid, but you should remind that this is a single injection. It's not like a continuous cure, and after 5 days, we could not continue with these experiments due to the limitations of working with zebrafish embryos. But it confirmed our enthusiasm that there is something that can be improved using these nanoparticles, either by sustaining the release or also by allowing for intracellular killing. So in this project, we went back to the bench, and because the organic component was more or less fixed, that seemed like a good combination, gelatin with vancomycin. So then we moved to the inorganic components, because we believe that for severe infections, you need to have multiple attacks on bacteria. So, and then we first started working with copper-doped glass, mesoporous bioglass, later on hydroxyapatite, spherical hydroxyapatite. All kinds of spherical inorganic particles that we would like to combine with the gelatin. And we like to work with spherical particles because of the viscoelastic properties. There's a better matching, as was asked before, like your gel integrity improves. There are also some indications, although not very convincing, but that spherical nanoparticles perform better than needles or plates or whatever. So spherical HA in an attempt to dope it later with zinc, and I'll explain later why we were interested in zinc. So first, the copper-doped mesoporous bioglass nanoparticles. That works very well. We tested their antibacterial efficacy. It was very abundant. Then we combined them with gelatin in these materials. And then here on the y-axis, you see basically bacterial growth in response to different materials. So the red dots are what happens if you don't treat anything. So then the bacteria can rapidly grow and proliferate. And then going down, we saw the antibacterial effect of these gels with increasing amount of bioglass. So basically the R1 is a material that has equal composition, so same amount of gelatin compared to silica. So that worked very well because the eradication is almost complete, like 99.99% of the bacteria was killed. Of course, it was 100%, but there's always something to keep dreaming. It's very difficult. This was MRSA, so it's a very resistant type of S. aureus. But of course, everyone asks the same when you start working with copper, isn't it super toxic? Yeah, it is, otherwise the bacteria wouldn't die. But we then tested also their response relative to other ions. There was another PhD student by the time starting. And we found in literature there has never been a really systematic screening of different ions in terms of antibacterial efficacy on the right against S. aureus versus toxicity for mammalian cells that you prefer not to hit too hard. So then you can see that copper indeed is antibacterially effective, the yellow line on the right and zinc as well. Some others are not, so they are claimed to be antibacterially effective, but they are not really that much, at least on this strain. But the interesting part was that the zinc offered for a more broad therapeutic window because the copper was indeed quite toxic for mammalian cells, these pre-osteoblast-like cells. And that's of course the downside, so you can't really add too much copper because then you start affecting healthy tissues. And for the zinc, that range was broader, so it was not so toxic for mammalian cells, but quite effectively killing bacteria. So we selected zinc for our second type of nanoparticles. And then in doing so, we found out something accidentally, that the combination of zinc and vancomycin worked very efficiently. So this is systemic release. This is not related to nanoparticles. But here you see what happens to bacteria if you don't treat them. Again, you see rapid growth, the top line. Then we had vancomycin or zinc, let's call it orange or something. And then, well, these two, basically. I'm very bad at colors nowadays. So low doses of vancomycin and zinc, there you could see that these low doses were not effective in killing the bacteria. But if we combined those two drugs at the same concentration, there was a synergetic effect, and very strongly actually. So you see with the green line that there was almost complete killing of the bacteria. It was quite exciting. We tried to patent it, and then we found out that there was just one publication 2 years before that we missed, so we couldn't patent, but it gave rise to, it was, let's call it another support for our research direction, that the combination of zinc and vancomycin is supposedly synergetic. So first, let's make then zinc-doped hydroxyapatite, because we wanted to move to hydroxyapatite due to this biomimicry. Bone is composed of gelatin and hydroxyapatite, basically, or collagen and hydroxyapatite. So we prepared the particles and then checked what nanomedicine researchers do. The internalization, you could see in the white overlap that the particles were abundantly internalized. And we observed some interesting features. For example, aging here. These open bars show that with increased aging, that means just like waiting longer before you proceed with further steps, the particles became more stable, went from amorphous to crystalline, and that was apparently beneficial for the viability or the metabolic activity of cells cultured in contact with these particles. So there was one indication, don't age too short, basically. And this was very interesting, so we added citrate, and citrate is an effective dispersant, which means that the particles do not agglomerate. And I guess those of you who work with nanoparticles know, like, you don't want agglomeration, because then you do all the efforts without any reason. You want to have the discrete state of the nanoparticles. And with citrate, that worked out very well, because it's negatively charged and it's abundantly present in bone. So we could keep them apart, but that reflected also in a way higher metabolic activity. So the stress caused on cells by nanoparticulate hydroxyapatite is way lower than agglomerated hydroxyapatite. And that's something I won't go into detail here, but we found out that that's really something to keep in mind. Then zinc-doped hydroxyapatite. Here we see the shape remains similar, and this is XRD, probably not very familiar to most of you, but keep in mind these patterns correspond to apatite, so we could confirm that there's no additional phases by adding more and more zinc, so there was up to 20% zinc. If we added more zinc, then additional phases were also formed, and that's not allowed, basically. You want to have apatite and not other phases that dissolve too fast, for example. We tested cytocompatibility on the left, which was quite okay, up to let's say 500 micrograms per milliliter. That's quite high concentrations. The particles are compatible. And above those concentrations with additional zinc content, the toxicity rose. So the zinc does something to those cells as well. But this is acceptable. So then we were very ready to test their antibacterial performance in bacterial culture. And that was quite disappointing because there was a very mild effect. You see, like with increasing amount of zinc, there was a bit of antibacterial effect, but it's for sure not bactericidal, so no killing, just slowing down. So basically all of these promising preliminary data did not reflect in the actual bacterial testing. Later we understood why, because when you work with bacteria, you have to work at a neutral pH, similar to cells. So you can't go to pH 6 or something because then the bacteria die right away. For a reason, actually. So, but that means that the hydroxyapatite, which is very stable at neutral pH, also didn't dissolve. So the corresponding zinc release was extremely low because there's no tool to get the zinc loose, basically. So this did not correspond to literature. So now we're in the process of starting a spin-off company. It's not an easy process at the UMC, I can tell you. Like we're in the middle of negotiations with our TTO and the holding and so on. Almost got green light 1 month ago, and then they were suddenly afraid for Gom van Stream kind of. Yeah, some of you know what happened, but I'll spare you the details. But they are very risk averse. So hopefully we get the green light soon, and then we could continue in starting a spin-off company headed by a postdoc who is really an entrepreneurial scientist, Rong Wang, together with Alexei Klimov, another postdoc with biological background. So I think we will manage to find a good term sheet and a good licensing agreement of the patent that we have on this technology. Yeah, that's then would be a happy story, at least for now, because like it's of course a pharma product, so we're not there yet. It will take years before we can treat patients, but surgeons are really enthusiastic and involved. So that's yeah, very inspiring for us. So that brings me to the end of this presentation. I hope to have convinced you that you can't just take materials from the shelf, add some drugs and hope that it will happen in a magical manner. So that has been done until now, I think, in the field. All the drug-releasing biomaterials nowadays available are mainly based on materials that were developed way before and then afterwards combined with a drug. So, but that's not the way to go, I think, if you really want to cure bone diseases. I think colloidal biomaterials are cool and they have some added value compared to bulk biomaterials, which I showed later on in the presentation. So this intracellular killing is of course not possible if you take just a bulk bioceramic or a bulk collagen sponge. There you have to really wait until you have small enough building blocks that can then enter the cell. So then I think that yeah, it's still a niche area, but colloidal biomaterials could be used, I think, in regenerative medicine or regenerative nanomedicine. So having said that, I would like to thank specifically the people that did all the work. Wan Wang, he started with organic gelatin-based gels, and Mani Diba took over with the composite gels. Jiang Kang, he moved from our lab to over here, but he showed for the first time that the particles can be internalized and kill bacteria inside cells. Rong Wang developed a whole battery of new nanoparticles, inorganic nanoparticles, and they were tested by Negar, Leah, and Lizzie. We collaborated with some partners that are listed here, and of course we would like to thank the funding that enabled the research. And I would like to thank you for being a very patient audience and attentive audience, and I'm happy to answer all of your questions. Thank you.
Congratulations for the work and
Thank you.
success for the company.
Let's hope. Yeah, this is a crucial phase.
Are there any questions? Curiosity?
Yeah, thanks a lot, Sander. Very nice work. I was wondering, you showed this one slide where you said the particles were aging. So you wait 10 or 60 minutes and something different happens.
Yeah.
But what happens at time 0 that starts the process that you call aging?
Basically, then we add the precursors together. So, no, that's not entirely true. So we have a calcium precursor and a phosphate precursor, which we add and stir, and then basically from that moment, time starts counting.
So that's where you basically synthesize those nanoparticles?
Yeah. It's time after synthesis, basically, yeah. Yeah.
Do I get correctly that that's just hydroxyapatite with zinc and there's no more vancomycin present in that?
No, so we have two components. One is the inorganic nanoparticle, that's zinc-doped HA. So the zinc is really inside the particle, inside the lattice, which we would like to combine with gelatin, which is then loaded with vancomycin. So that's
Gelatin was loaded with the drug still
yeah, yeah,
in that last.
yeah, exactly. And we show that both of them are internalized and then effectively killing the vancomycin. We could not observe the synergy that we observed systematically, but that's also because it's extremely difficult to get because it's only apparent at certain ratios, which is easily controllable in systemic manner. You dissolve the drugs. But to get that in cells, I don't know yet how to achieve that. Yeah, the uptake and yeah, just maybe for the next 20 years. Yeah, but so hopefully there will be a sweet spot where they will be synergetically effective. Yeah.
Any other questions?
Yeah.
In one of your last slides, you showed a little bit of how you think this material can be used in a periprosthetic infection. Right? And you showed a picture of injecting in to various locations. So are you implying that you don't need to remove the implant?
Yeah, that's what we're discussing with the clinician. They don't know yet, because they say if this works, we'll just find a way. Or it could be smearing around the implants. It depends really on the procedure. You have one-stage procedures, two-stage procedures. Some surgeons even indicate you could use it prophylactically, but it's very difficult to get consensus because different hospitals have different treatment regimes. It has no load-bearing capacity. Yeah? That's way. So it should be like something you could apply surrounding such a hip, for example. Some hip surgeons just indicate just doesn't matter. There's space. We'll just get it in there. Yeah.
And you don't think that the delivery and distribution of your material has any effect on its antibiotic capacity?
Yeah, that remains to be checked. Yeah. Although I'm pretty convinced because the zinc is really stored in the lattice. That's really because I didn't explain carefully, but what happens, the major difference between extracellular antibacterial efficacy, which was very low actually, and intracellular was the fact that they are in the lysosome, and as shown in the confocals. But the lysosome is acid, so then it's reduced. The pH goes to 4 or 5 or something, and hydroxyapatite dissolves. So then the zinc is released. So it's really a biological mechanism. And the zinc is really stored abundantly in the hydroxyapatite. So I'm not afraid if you extrude it in one way or the other that it's then released in a different manner. The vancomycin could be affected, but we checked that the vancomycin binds quite strongly to the gelatin. So we tuned the type of gelatin to basically the charge of the vancomycin. And that's a benefit, but it's more sensitive because the vancomycin is loaded after particle synthesis. So we first make the gelatin particles and then basically soak it in vancomycin solutions, and then you get quite a strong affinity. And so far it survives our handling at least, but the orthopedic surgeon is usually less sophisticated. So yeah, remains to be checked. Yeah.
Any other questions?
Welcome.
Do you ever consider using silver instead of zinc because it has antibacterial activity?
Yeah, we considered, but in the end did not do it. It would be possible. Silver nanoparticles are often used, mainly due to toxicity reasons. It's quite toxic, so it's more in the same range, I would say, as copper. It was not included in this slide, but silver is quite toxic to mammalian cells. Yeah, and also very pragmatically, also scientifically, I was not very enthusiastic about, because silver has been used since the Romans, and we have to publish also. So, yeah.
So using zinc, you're also potentially killing cells as well. Have you thought about how that affects the regenerative capacity
Yeah.
around that area?
Well, I'm not really concerned there because, of course, but everything is toxic, even water. But so the concentration that we observed will not be easily reached in cells. And as an internal control, this intracellular bacterial mammalian cell culture co-culture model I forgot to add, but all the cells remained viable. So we checked that the host cells were not killed. So only the bacteria inside those cells were killed, but the cells themselves were viable. So they could manage the bacteria. That was, of course, a matter of dosing. If you add too much bacteria, they will be killed. But the host cells were still alive. So, yeah. So I think that could work out then.
Then in view of time, I suggest that we conclude here. Sander, thank you again.
Thank you.
For
Yeah.
the nice time. Yeah.
Thanks.